everybody. My name is Ken Masson. I am the president of the Rotary Club, the World Disability Advocacy. My apologies, I have dogs barking in the background as I'm in the city of Columbia. And the Rotary Club of World Disability Advocacy is a global group that works on and focuses on the advocacy of human rights for people with disability around the world. And I'm glad to be here actually with one of our members, Dr. Leslie Rogers. And today's topic I'm really interested in because when you start looking at some of the statistics on this topic, it's pretty amazing. So, Dr. Rogers, welcome. Why don't you tell us a little bit about yourself?
Hello, everyone. How are you? And don't worry, the dogs. Let me tell you, I had to put my dogs upstairs in the room and shut them up. We are working from home and in the comfort of our living rooms and things that sort. So you're okay. Um, hello, everyone. My name is Dr. Leslie Rogers. I'm a psychologist out here in North Carolina. And just to give you guys a little bit about myself, I grew up in Washington, D.C., went to school there, college there, and went off to graduate school and finished my internship in Memphis, Tennessee, and then landed in Fayetteville, North Carolina, where I worked with first responders and veterans actually. Um, I left the VA and started my own business, Mental Health Talk, and there is when first responders came in. Started working with first responders, providing clinical support, and I love it. From there was born Mental Health Talk magazine and Men Suffer Too, where we work to decrease stigmas around men and getting men to open up and talk, which is what we're going to talk about today a little bit in those gender differences with mental health. Um, and yeah, that's about it. To round it up, many of you don't know I was with the FBI for 25 years um, as an intelligence analyst and left there and started a career in psychology. So here I am today on stage with Ken and the Rotary Club and talking about mental illness, and it's just a beautiful thing.
Well, I'm so glad we can have this conversation, and I'm glad that you're now a member of the club because we work on a global level, and that opens you up to a global level. So we're
Hmm.
going to be a lot of things we're going to be doing on that level.
Right.
So let's start out. There is mental illness and there's mental health. Those two terms. Can you kind of give us a definition, or at least a description of what the difference is between mental illness and mental health?
Absolutely. So mental health is how we collectively take care of ourselves. I often say, look, think of mental health as being an umbrella, right? And then you have raindrops. The umbrella is protecting you from raindrops. It's protecting you from the sunlight, right? Imagine mental health as an umbrella, and then mental illness is the raindrops that's falling on the umbrella, or the sunlight that the umbrella is shielding you from, right? Mental health is how we collectively take care of ourselves, the whole picture. Mental health is how you go to doctor's appointments, how you get physicals done, how you make sure your body is okay. Mental health is how you get up in the mornings and go to work, how you're effective on your job. Mental health is self care, right? Mental health is collectively how we take care of ourselves and how we interact with the world on a day to day basis effectively, right? And then mental illness, guys, is are treatable uh, disorders. There are diagnosable disorders that's treatable, right? Mental illness. And I like to, so I don't know if a lot of people split this up, but I do. Mental health versus mental illness. And I split it up because there's a lot of stigmas. And when you talk about mental health, I believe that people are resistant to talk about mental health because they're thinking of mental illness, right? So they're not, if we can collectively talk about mental health to reduce those stigmas, then we can slowly talk about mental illnesses. But mental illnesses is actually what people are kind of hesitant to talk about because that's where the stigmas fall.
Okay. So and today we're going to talk about both or one or the other.
Well, today is again, I think it's a good idea to talk about both, but the focus is on mental illness. Again, mental health, you can't talk about mental illness without talking about mental health. However, the spotlight would be on mental illness because that's what people kind of back away from, especially when you're talking about gender differences.
Okay, because I'm thinking of, for example, depression. There are two levels of depression. One is temporary depression, and the other is clinical depression. So, clinical depression would fall under mental illness.
Right. And I don't know what do you mean by temporary depression?
Well, for example, if I had a bad day, and for the
Mhm.
next 2 or 3 days, I'm basically not feeling like doing anything because I'm
Uh-huh.
depressed.
Yeah.
Eventually, that will end. At least,
Mhm.
I think so. I think
Yeah. See,
that would
yeah.
end. But if I have a clinical depression,
Mhm.
that's a whole different thing.
Yeah. So then you're not depressed, right? So I think that we all go through our downs, right? Our down days. Even Dr. Rogers does. Sometimes I get down where I don't want to get out of bed. Sometimes life knocks me on my behind and I don't want to get up. I don't want to go to work. I
Hmm.
don't want to be around anyone. But that doesn't mean I'm depressed, right? It just means that I'm going through life, right? And you can't
Right,
go through life without having a bad day. Clinical depression is when that doesn't improve, right?
right,
It
right,
you just don't get better. You
right,
keep thinking in that hole. You can't engage. You're withdrawing. You're isolating. And a lot. And we'll talk about this later when you ask about the question around mental illness. But clinical depression is just that. It's like it interferes with day to day involvement and engagement. But again, I wouldn't say temporary depression because either you're clinically depressed or you're not, or you have a disorder or you don't. You know what I
right,
mean? I think
right,
that uh, we should think of things as sometimes we do get anxious. I even get anxious, right? But I'm not diagnosed with an anxiety disorder. Sometimes we do get down. I get down and
right,
sad. Sometimes I even cry,
right,
right? But I'm not diagnosed with depression, right?
right.
So you either have the normal day to day experiences, or it can go into potential disorders.
Okay. So,
Does that make
because
sense?
mental, yeah, yeah, that's fine. That's good. Did a good job on that. um, Sometimes, no, where I get going. I mean, mental illness is a full range of categories on that. It's just a wide range from some of them are very serious and some of them are less serious. I don't hate
Hmm.
to put it in a category like that because of so um, is now let's talk about, is it treatable? Is it curable? Is it preventable? And maybe can you catch mental illness from some other person? That sounds like a silly question, but it's something people are concerned
It's not. I'm writing this down because I want to answer this because I like these questions. Curable, because a lot of people think, you know, to for me to say cured means that you have a disease, right?
about.
Like, is cancer curable,
Hmm.
or if is diabetes curable, right?
Hmm.
Um, I'm more so like, is it treatable or is it
Hmm.
preventable, right? So I'm going to talk about either prevention or treatable, right? So prevention, is it treatable? Absolutely. And mental illnesses are treatable. They're diagnoses and they're treatable.
Hmm.
Um, and yes, you potentially can prevent, mental illnesses. Again, by engaging in self care, by being aware of family histories, by uh, being able to openly discuss, problems and talk about what you're going through, by normalizing experiences. Is it treatable through therapy, through medication, potentially? Mental illnesses are
Hmm.
treated. Oftentimes, I often tell people to get medical checkups to make sure it even is a mental illness,
Hmm.
right? Because there's so many overlapping symptoms of medical conditions and mental illness.
Hmm.
For instance, I have hyperthyroidism, and I sometimes feel like I'm anxious a lot because my heart just races all the time,
Hmm.
right? But my thyroid levels are really high. So sometimes that can mimic anxiety disorders. Hypothyroidism can mimic depressive disorders. So I always say go to your doctor and rule out medical conditions first before you consider mental illness.
Okay, good, very good. So let's Is Are all mental illnesses serious?
So no. And I want to say this too, not all times people are diagnosed with mental illness.
Hmm.
So this is an important thing to know. We use something called the Diagnostic Manual, Diagnostic DSM, Diagnostic Statistical Manual for Mental Disorders, and we use that to diagnose. And there's a caveat in there to diagnose must cause clinically significant impairment in multiple settings. And I'm paraphrasing, guys. Must cause clinically significant impairment in multiple settings, which means that it significantly impacts your day to day living. A
Hmm.
person can come to me for symptoms of depression or anxiety, but they might not necessarily meet the criteria. They might just need to build coping skills to help deal with whatever it is you're going through, especially like adjustment disorders, right?
Right.
Adjusting to a new job, or adjusting to a new marriage, or adjusting to a new baby, right?
Hmm.
So there may not be a diagnosis, like an active diagnosis. When you talk about mild to severe mental illnesses, we do have that, and I often put it on a spectrum from neurotic, borderline, and psychotic, mild
Hmm.
to severe, neurotic, borderline, and psychotic. And when you're talking about psychosis, like hallucinations and things of that sort, that may be managed by better managed by medication along with therapy, right? So yes,
Right.
there are mild to severe mental illnesses that are treated. Some are treated similarly, and some are treated differently, and some are managed differently.
Okay. And certainly a serious mental illness situation would be somebody who would do harm to themselves or maybe others, and that's probably
That's a part of it. That's a part when you're
yeah.
talking about self harm and thinking of suicide and things of that sort.
Right. So, and is it age? This maybe I'm not wording this right. Can all ages deal with mental illness? For example, can a child who's maybe under 10 years old may be dealing with mental illness?
Absolutely. And I sent you a research, and guys, that if anyone's looking at this and follow me, guys, that I'm big on research. So let me go back to this. I want to go to this research article really quickly, Ken.
Okay.
And I sent it to you. Um, and what it's essentially saying is that here it is right here. Uh, Mothers who have depression, babies can be depressed as well. So as early as young babies can experience depression, like disconnection. Not, and I want to find this really quick. Here it is right here. It says, depression can cause mothers to be inconsistent with the way they care for their children. They may be loving one minute and withdrawn the next. They may not respond at all to their children's behavior, um, or they may respond in a negative way, depending on how the children are. They will be affected by their mother's depression in different ways. For
Hmm.
instance, babies, and this is young babies, to answer your question, babies may have trouble interacting with their mother. They may not want to be around their mother. They may get upset easily. They may be withdrawn, develop skills later on than other
Hmm.
babies. Toddlers, we're going up. Toddlers may be less independent, be less likely to interact with other people, have more trouble accepting discipline. School age children may have behavioral problems, may have learning difficulties. And you go up the line as far as you know, is there age differences? And absolutely, children can suffer from depression, can be anxious at young ages, such as and develop social anxiety, separation anxiety, right? Um,
Hmm.
so yes, children can experience mental illnesses as well.
Okay. And we talked about different levels of seriousness, and I mean, when does it become serious? You should seek professional help.
When you start noticing differences, so and pay attention to your children and pay attention to yourselves, right? When you start noticing differences, is it impacting school? Is it interfering with school performance? Is it interfering with work performance? Is it interfering with day-to-day interactions like family? Is it creating family conflicts? Or are you especially down today more so than other days? um, are you not able to get out of bed? Are you losing interest or pleasure in
Okay.
something that was once pleasurable to you?
Okay. And so now let's talk a little bit about, or a lot about, where there are differences. For example, we wanted to talk about the differences, how men and women approach mental health. And so, what are the gender differences?
So yes, there are gender differences in how we present, and they're universal. Research shows that some of these gender differences are universal, meaning that it's not only isolated to U.S. but to other countries as well.
Hmm.
Um, Men may present externally, externalizing, and women more internalizing, meaning men may present as angry, irritable, may have physical outbursts. Um, Research shows that substance use disorders are higher in men, right? And then women are often diagnosed with anxiety and depression, according to research. And sometimes, and this is important as well to know, Ken, that sometimes we as the mental health professionals get it wrong when we're diagnosing men versus women, because we may miss, because men underreport symptoms often. We may diagnose men with externalizing diagnoses, such as substance use, such as schizophrenia, or something else, right? As opposed to depression, right? And I saw it a lot when I was working in an inpatient hospital, where a lot of men was diagnosed with instead of like bipolar, they were diagnosed with schizophrenia, right?
Right. So, and um, and obviously, in I know in the United States culture, and probably in many cultures around the world, society puts a lot of pressure on men not to be weak. Men have
Oh,
not
absolutely. Hmm.
Women have to be the same, but women are uh, they're more comfortable with their emotions than men are. So,
Yeah. But wouldn't that, and having this discussion, I know we're in an interview, but having this discussion, wouldn't that make sense though, how we raise our kids from babies? We raise, and it's starting to have a shift now, because, society is changing. But how we used to raise children, with those gender differences, girls were the little nice, tender, kids, and boys were tough and rough. And girls, we dress them up a certain way. Boys, we dress them up a certain way. Girls are
hmm
supposed to act this way. Boys are supposed to act this way. Girls are supposed to cry. Boys aren't supposed to cry, right? So
hmm
then, when you grow up, and you've grown up in such of this ideology, then you think, well, we have to be tough. We can't cry. We have to tough it out. And then when you get into certain work environments, such as military, law enforcement, and other environments, that ideation is kind of supported and validated. So, it can, and that's when you talk about those stigmas.
yeah, and I wonder. I mean, you're not born that way. I don't think. I think you're
You're not born
taught
what way?
that. Well, you're not born, like, for example, for a man to be more macho or whatever it is, be
Mhm.
less open with their emotions, and women the other way. I don't. Maybe I'm wrong, but I don't think men and women are born that way. I think um, so. That's a question I need to ask.
Yeah.
How does that happen? Is it something ingrained? Is it something that family values, or is it society that causes
Yeah.
that difference?
Yeah, I think, that falls in line with that nature nurture debate, right?
Hmm.
How much is it nature, biological, and how
Hmm.
much is it, nurturing? And what you're talking about is the learning piece. How much is it how much of it is learned? And of course, we grow up, in our families, and we learn a lot. We take a lot from our families. Um, but when you talk about mental health and mental illness, I believe that from a young age, it starts as to how your family deals with mental illness. Is it openly discussed? and immediately handled, or is it avoided? Like, is dialogue had in your families? When I was growing up, it wasn't openly discussed, right? And then when you talk about that cultural aspect and gender differences, such as men and women, then you have to think about culture as well, because as a black female growing up in a black home, men didn't have time to think about mental illnesses. They had to work, they had to take care of home, right? So then you think about the cultural piece as well. So when you think about what what's the contributing factors or motivative factors towards mental illness and accepting mental illness, is family, social, institutional, culture. What does family say about mental illnesses? What is socially, when you get in school and other places around your other friends and etc.? What do they? How do they handle mental illness? Institutionally, when you're in work settings, how is mental illnesses handled?
Hmm.
When I was in law enforcement, although we had a component there to deal with mental illnesses, um, uh, some things was almost skipped around, like suicide, talking about suicide, right?
Hmm.
Culturally, what does culture say about mental illnesses? And you asked a question earlier: is it contagious? You know, you said sometimes these questions. Oh, I wonder if this question sounds silly. No, because a lot of people I have heard different cultures ask that same question: is it contagious? For instance, if you think about schizophrenia, I mean, you know how many cultures believe that it's contagious?
Right. And it's a lack of understanding basically that
Mhm.
causes that. So.
Now, there's a genetic component, and a genetic component to schizophrenia, to bipolar, which, by the way, has one of the highest genetic components there is, right?
Hmm.
Bipolar is the highest, schizophrenia second highest.
Hmm.
Depression has a genetic component too, but and that simply means that if and this is based on twin studies, if a parent has schizophrenia or bipolar, then the children are at high risk for depression,
Hmm.
bipolar, schizophrenia.
Okay. Interesting. And of course, I hate doing it, but we're putting people in categories which we really shouldn't. But it's statistics kind of back what you're saying. I mean, obviously, there are men that are very open with their emotions, and there are women that are very close with their emotions.
Mhm.
So, but overall, based on statistics, what we're talking about is in general situation as opposed to putting somebody in category. I was talking with somebody who's very open with a male who was very open with his emotions, and you can't imagine the pressure that was put on him because of that. They were saying like get over it and all that kind of stuff, you
Mhm.
know.
Yeah.
And you sent me an article. I mean, I'm just talking about statistics. Let's see if I can take a look at it. About statistics. I think this is from England, but I'm sure it's still very
Hmm.
related to the rest of the world. Let's see some of the statistics that are on here. 80% of men have trouble sleeping versus a smaller percentage of women. Um, let's see, the level of suicide is much higher with men than it is with women. Uh, Men become more, 3 times as likely to become dependent on alcohol and drug use. Um, Men are likely to be victims of, are more likely to be victims of violent crimes than women. Men are more, vast majority of more men are in prison than women. And now this says women are twice as likely to be diagnosed with anxiety. Well, maybe because women are more willing to admit that they go
Hmm.
for help on that. So I mean, those statistics I would assume all kind of support the idea that men are keeping things inside, and this is causing issues like alcoholism. You know, it's
Hmm.
the way to deal with it as opposed to going to therapy.
Right. Hmm. So then, what would be important is to encourage self-help behaviors, right?
Hmm. Yeah.
Yeah.
And encourage self-help behaviors, but encourage the fact that it's okay. It's okay
Hmm.
to seek
Yeah.
help.
Yeah. Help seeking behaviors, and let people know it's okay to not be okay. Um, yes, and I thank you for reading that article because again, and I wanted to send you the articles, and yes, it was from what did you say, England?
Yes, from England. Yeah.
Yeah, it was from England, but I wanted to send you that article to show that some of these symptoms are presentations are universal, right? The way
Hmm.
people these gender differences present are
Hmm. Hmm.
universal, and you see them in
Hmm.
other countries as well.
Hmm. And let me just take a minute here to do a little advertisement for the club. I am the president of the Rotary Club of World Disability Advocacy. We again work on human rights for people with disabilities. We advocate for them around the world. Dr. Rogers is a member of our club. And if anybody's interested in getting involved with our club, we meet virtually and we do work locally and virtually. So you can reach us at rotarywda@gmail.com. That's rotarywda@gmail.com. Okay, so let's get back to this a little bit then. And we're talking about the men and women treat mental illness differently. How about the treatment for men and women? Is it different?
Right. So again, so treatments are pretty standard. There's tons of treatment for mental illness, treatment models, and there's tons of them. Um, and they're often modified to meet the needs of the person. Each person has different needs. For instance, um, two people can be diagnosed with depression, right? But they may have
Hmm.
different symptoms or presentation. They may present differently. So we may need to modify the approach to therapy. Trauma therapy. When you talk about trauma work, um, I may do trauma work with a female, but I may modify it a bit to meet the needs of a male or law enforcement or first responder, right? So it
Hmm.
depends on the needs of the patient based on the treatment, but the treatments are pretty much the same. You just can modify it. And then you do an integrative approach where you can combine several treatment models to help
And
individuals with mental illness.
And I would think that the men that go for treatment are the ones reaching out, so they're the ones more open to the whole thing. Obviously, the concern are those that are not going for treatment at this point. And
Right.
um, I'm thinking about, I don't know, maybe I'm wrong, but maybe the person with
Mhm.
mental illness is the last to recognize it. And is that true?
It depends. It's just like a person with a substance use disorder, right? They might not recognize it up front that they have a problem. Um, until one, I often say when they're ready to recognize they have a problem.
Hmm.
But sometimes it takes not it takes the encouragement and it takes the support and the compassion to be able to speak with someone about problems and encouragement to seek help, right? But yeah,
Hmm.
men and women do come and seek treatment. I often say with men, when we talk about men, so when you go to Ken, when you go to a seminar and you see statistics listed on the wall, I don't know, maybe you can tell me if you have, but you see
Hmm.
stats on the wall about trauma. Who are the stats about? What are they representative of?
Trauma to somebody or trauma to
I
being
know, but
caused by
when
something?
you with regards to gender, men and women, they're mostly about
Um,
women.
yeah, they are mostly about women. That's correct. Yeah.
Right, right. So if I'm a man and I see all the stats, the stats that's presented on sexual trauma and other types of trauma, the numbers only represent women, then why am I going to come forward and talk about my trauma as a man? I
Right.
mean, I'm
Right.
not even represented in the stats,
Right. Right.
right? So I think that we have to be more willing to, because I believe we have enough men that's reporting to have statistics to cover men and sexual trauma and things of that sort. I do believe that. And there are statistics and research out here that cover that as well. But again, because of underreporting, I don't think is where it needs to be. So
Hmm.
men are coming forward. I don't want people to think that men aren't coming forward to talk about mental health and mental illness and to
Hmm.
engage in therapy, because they are. And men are coming forward saying that they're victimized. Men are coming forward, right? And I
Hmm.
think that that opens the door for other men to follow suit and come forward as well, because what it does is normalizes um, the experiences, and it validates their experiences too. We have to get out of that thing of invalidating men so that
Yeah.
they can feel comfortable with talking about their experiences and telling their stories. And we have to start, I think, at young ages. We have to start
Okay.
talking to our young boys as well.
And you and I, I'm looking at this notes that we talked about the other day, and you had brought up a question about the resources being different in different cultures. I would imagine culture in the United States versus a culture in Africa or Asia or obviously South America.
Yeah.
This whole thing is going to be different. Um, and in cultures, and obviously, I would think that different cultures too are at different levels of development as far as the difference
Mhm.
between men and women.
Mhm.
Am, am I going off on a tangent to that?
No, I was
And,
listening to you. I was just listening to you. It depends on the availability of resources too.
right,
You know, we in the United States have a plethora of resources, right? When you go to
right.
other countries, depending on what their resources are. I think I mentioned to you I was on Clubhouse. Clubhouse is a social thing where you go on and talk about different things. And
Hmm.
there were people that were contacting me from all over the world, in Middle Eastern countries and other places, asking if I could provide them resources or help because they didn't have mental health clinicians there, right?
Hmm.
So, there's a lack of resources in some cultures. And then you have to understand how the cultures, what's the belief around mental health and mental illness. When I have someone come see me and they're from another country, the first thing I want to know about is acculturation, when they came to the US, and how was mental illness handled in their cultures versus now, and that adjustment and that transition. Um, so it's important to understand how cultures handle mental illness, because in some cultures, mental illness is considered a disease and contagious, because I've heard it.
Hmm.
Right. So understanding how what the belief systems are around that and what resources are available in those cultures. So during like for instance, I'll give you another example. The um the Israeli war that was going on with Hamas,
Hmm. Hmm.
um, they actually set up a volunteer committee, which I was on, a volunteer of mental health professionals to provide
Hmm.
services to them. So what I did was push out that information to Israel, right? But it was a volunteer based thing. That was a resource for mental health uh, discussions and things of that sort. But not everyone have those opportunities.
Okay. And so, getting back to the question I was talking about before, where we talked about the fact that maybe the person who has a mental illness is the last to recognize it. It's possible. Or in denial of it. No, no, I'm fine. Don't worry about it. Or they think maybe I have some sort of mental illness, but um, they're suppressing it. They're suppressing it as best they can. So I would assume that oftentimes the people to recognize it are the family or friends. So, what is your advice to family and friends that may be feeling that there is somebody in their circles that could use help but are in denial? Do you have any thoughts on that?
Yeah, absolutely. And I will say to deny means avoidance. It's avoidance. Um, avoidance for a number of reasons. We avoid to deal with mental illness because it potentially keeps us safe. Avoidance, I believe, is a safety tool that keeps us safe. Um, so it's important to have open dialogue, and family members to have open dialogue with persons and to understand what mental illnesses mean to you. Every person defines mental illness differently. based on a lot of different things that we talked about, based of child rearing and other experiences. Um, Validate experiences. Family members should always validate experiences. And I put down here in all caps, guys, be quiet and listen.
Mhm.
Be quiet and listen. That is so hard for us to do because sometimes we're so judgmental, right? And we're so quick to tell people what we would do, right? Without listening to really what they're going through, right? So be quiet and listen. Become active listening to what your loved ones are going through, right? And encourage help seeking behaviors as family members. Um, be proactive. Find out what the resources are in your area. Like star 988 is the crisis hotline. But find out like other resources that's in your area. Even when people are dealing with medical conditions, because medical conditions can trigger mental illness as well, right? See what support groups or what resources are in your area to be proactive and say when you're talking to your loved one, hey, I was on some research and I found this resource in the area. I'm going to give this to you and maybe reach out to it,
Mhm.
right?
Mhm.
Encourage, reaching out and things of that sort. I think you know, people like when you give them like solutions, like resources and
Mhm.
things of that sort, as opposed to being judgmental and
Okay.
non-compassionate.
The thing is too, and it's right. The going. I'm thinking about Google, and I know my medical doctor always says, "Don't go to Doctor Google." But and I'm sure in the same case with mental illness, maybe it's helpful from a standpoint, but don't do self-diagnosis or don't do a diagnosis. I would think it's better to go to a professional. Correct.
Ken, let me tell you, when I first became a doctor, I had every disorder that was in the DSM. Before I became Dr. Rogers, I was diagnosed with depression, bipolar, personality disorder, everything. Right? Yes.
Yeah.
But you know what, Ken? We all want to, we go through things and sometimes becomes a bit scary. So what we want to do, we want to understand what we're going through. So we go to Google and we go research to kind of come up with describe what we're going through, but sometimes that can be dangerous because like you said, we can misdiagnose ourselves. We can again, you go to Google or everything else, we'll see so many symptoms that we are similar to what we're feeling and how we, I mean, even I have scared myself thinking I had cancer before because I was, think it, again, it's best to go to the doctor, go to the professionals and
Mhm.
see what's going on. Again, go to your doctor, rule out medical conditions, and then get engaged with a mental health professional. But yes, you're right. That causes anxiety when you're self-diagnosis. It potentially
Right.
causes a lot of anxiety.
Right. And now I forget the question I was going to ask you because you were because oh, I know. So the because even with the professionals, some mental illnesses are not easy to diagnose and could take years. For example,
Hmm.
schizophrenia is not an easy mental illness to diagnose. Correct. So I mean, even for professionals, it's complicated.
Well, I mean, if a person has schizophrenia, they're presenting with, hallucinations, delusions, and psychotic symptoms, right? Um, so it all depends on how the person is presenting, right? But for instance, you can have schizophrenia, or you can have depression with psychotic symptoms, or you can have bipolar with psychotic symptoms, right? So the
Hmm.
difficulty isn't diagnosing schizophrenia. Maybe the difficulty may come in determining whether it's solely schizophrenia or is it depression with psychotic symptoms, right? Or is it psychosis due to trauma, PTSD, right? PTSD, there may be some psychosis there or something that looks like schizophrenia or looks like, depression with psychotic symptoms. So it's
Hmm.
ruling out disorders with comorbid symptoms, right? Or differential diagnosis is what it's called. It's understanding differential diagnoses and being able to decipher concretely by ruling out diagnoses what exactly it is. So it
Okay.
might not be exactly suicide that's difficult to diagnose, is ruling out other diagnoses.
Okay. And I remember I was working with a gentleman one time, and he was diagnosed with borderline schizophrenia. Is that possible? You can have borderline schizophrenia? Are you schizophrenia or you're not schizophrenic?
Well, borderline schizophrenia, there's not a diagnosis. Maybe that's maybe that's what he was saying. Maybe that's what he understood the diagnosis to be.
Yeah,
But yeah,
yeah,
so again, the diagnoses are so concrete, right? It's schizophrenia, or it could be a brief psychotic disorder, or it could be a schizophrenia form, or it could be other components of schizophrenia, right? But they all
right,
still have the presentation of schizophrenia, but they differ due to time, due to onset, due to length of presentation. So there's a lot that go on with a diagnosis, and that's with every diagnosis. It's
right,
based on the criteria is based on the duration, the onset, and other factors that go into diagnosing disorders. You don't just diagnose a person with depression just because they come to you and say they're depressed. They have to meet certain criteria.
right. And certainly a person could have multiple disorders. I mean, so
Absolutely.
yeah,
Hmm.
yeah, yeah,
Yeah, and
yeah,
that's called comorbid. When you talk about comorbidity, a person can, like for instance, a person can have ADHD and anxiety, or ADHD and depression. A person can have. So because people can have multiple diagnoses, what I do, a rule of thumb for me, because a lot of diagnoses overlap symptoms. So I do psychological testing, of course, but if a person comes in and has trauma and say that they have ADHD, I often ask questions, because sometimes they can believe they have ADHD because symptoms like not being able to focus, being disorganized, and other symptoms of ADHD might be direct correlation with the trauma experience that they've
right,
experienced. So it might
right.
not be ADHD.
And there's a difference between mental illness and things like the neurological disabilities too. You don't want to confuse the two on this because they're
Yeah.
whole different world on
Yeah,
that.
such as dementia, and such as dementia, pseudo dementia versus real dementia, right? When you're talking about with pseudo dementia, is more clinical aspect. The person gets better. With true dementia, there's a decline in symptoms
Okay,
presentation. Mhm.
okay. So let's. We talked about men and women. What about cultural race differences? People have different race. Is mental illness in it treated in different ways, or not treated but dealt with in different ways?
No, it's still so when you talk about race and culture, you're still what's important is understanding that person in the cultural aspect, right? For instance, maybe understanding oppression in a person of color, or cultural diverse person, their history with depression, right? Understanding that when going into therapy, right? So yeah, there are going to be not going to be differences in treatment, but it's the way you understand. You have to understand what their life is, what their experiences are, so that you can treat and so that you can modify treatment approaches accordingly. So again, you're not treating people differently based on race and age and things of that sort. You're modifying different treatment approaches to meet their needs based on where they're at in therapy. Does that make sense?
Yeah, makes sense. I appreciate that answer. But I'm thinking too. I mean, um, a person of a different race who might be considered a minority in a country,
Hmm.
um, and has a mental illness, they in reality have, um, as far as society is concerned, they have
Yeah.
misdiagnosed, but two strikes against them as far as society. If you understand what I'm
Yeah.
saying, yeah,
I do understand what you're saying, and I'm glad you bring that up because, blacks are misdiagnosed, especially black men are often misdiagnosed, right? Black men are often misdiagnosed for schizophrenia. Their uh, research shows that they're, especially when you're in patient settings, diagnosed with a high rate of schizophrenic diagnoses, right?
hmm,
So again, we as psychologists and as mental health professionals have to be culturally competent, meaning, we have to be culturally sensitive, and we have to be aware that based on your race, you can be misdiagnosis if you don't understand that culture And
Right.
again, I'll give you an example. A person diagnosed with schizophrenia, a black person diagnosed with schizophrenia, right? I have to make sure that is it a religious thing? You know, a person says that they have an out of body experience, or you know, a lot of uh, I grew up in a religious family, right? Where you know, in my family, they have out of body experiences, or that's due to religion, right?
Hmm.
Are they schizophrenic or having hallucinations, or you know? No.
Hmm.
People
Hmm.
hear God, right? Are they
Hmm.
having delusions or hallucinations of uh, audio hallucinations because they're hearing the voice of God? No, right? But you
Hmm.
have to understand that so that you won't misdiagnose them with a psychotic disorder,
Okay.
right? So you have to be able to understand who being culturally sensitive and culturally competent is really important in practicing in this area.
And this is a subject. The whole thing we talked about in the last 45 minutes is something that we could talk about for a long time, for hours, because it's
Mhm.
so complicated, and it's personal and it's emotional, and a lot of people um, deal with it. So it's something that really we're talking 45 minutes here, but we're only talking the surface of this whole thing, just to try.
Right.
But what I'm hoping for maybe is that there is somebody watching this who, based on the what we talked about, are starting to think, okay, well, maybe either myself or somebody I know may be dealing with mental illness.
Mhm.
And they're thinking, okay, now what do I do? What do I do from
Mhm.
here on? So this is maybe kind of my final question, kind of wrapping up, so we can kind of leave a little bit of. We talked about
Right.
the problems, but if we could talk about a solution at this point.
Mhm.
I know you touched
Yeah.
upon it a little earlier, but maybe we can kind of give a final answer to the people watching.
Absolutely. Absolutely. Pay attention. You know, if there's any changes in behaviors, changing in mood, changes in demeanor, that's out of character, you know your loved ones, right? Especially with children. Pay attention. And, you know, approach them with sensitivity. Be sensitive and compassionate when you approach them to normalize, you know, and validate their experiences. Learn how to speak openly about what they're going through, right? Even disclose, use self disclosure. I tell parents all the time, especially when COVID was going on, you know, self disclose what you're going through, the anxieties that you're going through, you know, with certain situations to normalize what kids are feeling so that they can feel comfortable with saying, wow, mom, I feel the same way. My heart beats sometimes and things of that sort. We didn't get into that, which we can do another time. You know, different types of symptoms, you know, children present with, right? Who's
Hmm.
anxious and things, which is important to know.
Hmm.
Um, Consult with medical professionals to rule out medical conditions. And again, this is really important. Practice how to communicate experiences. I often give people because we as adults too, not just children, have
Hmm.
difficult have difficulty putting labels to what we're feeling. We can't identify words, and then we become frustrated and irritable.
Hmm.
I use this thing called an emotions checklist. You can print off of Google for adults and for children.
Hmm.
Emotions checklist. Hundreds of emotions on there that'll teach you to be better communicators, help you
Hmm.
identify what you're feeling, and then you can communicate to your loved one and to others what you're feeling. And lastly, not star 988 again is what is it called? A crisis hotline. A lot of people ask me, Dr. Rogers, can I involuntarily commit my loved one? You know, if the person is of age, no, you can't, unless you think
Hmm.
that the person is actively going to harm themselves or are suicidal and
Hmm.
you know, a danger to themselves or others. You can't, you know, just take your loved one to the hospital and commit them, right? So
Okay.
the best approach to that is give them resources, talk to them about available resources, what's out there,
Hmm.
and speak with them in a compassionate way, and let them know that you're there for them to support them and encourage help seeking behaviors. There's nothing wrong
Okay.
with that. Encourage help seeking behaviors.
Very good. And of course, the concern is too that, like with any profession, there are good therapists and there are bad therapists. So I mean, how are you gonna make sure you get somebody who's good? I mean, that's
Yeah.
Is there a resource to go to find a good therapist? I think you're on one
So
of them.
yeah, Ken, that's tricky. Because you one thing I want to say, you have to be careful not to self sabotage yourself, because a lot of people go into the therapeutic environment already resistant or guarded. You know, they can be a little bit biased when they come into the environment, not giving it an opportunity to be good, right? So, I think that in determining whether or not you're a good fit or the therapist is a good fit for you, you have to give the process a chance. Go in with an open mind. Go in, let your guards down a little bit, become vulnerable, because vulnerability can sometimes be hard and scary, especially based on prior experiences. So be vulnerable a little bit. And if you find that the person isn't a good fit, you'll know. Another thing, and I have to say this, Ken, before we end, every all psychologists or all mental health providers does not deal with trauma. So that's another thing with dealing with whether a goodness of fit, because when you go into a clinician's office and you're dealing with trauma and they can't help you, and you're not getting your needs met,
Hmm?
you really need to ask before you engage. Do you work with trauma? Do you work with
Okay.
PTSD? Right? Because that's
Right.
important to know, because not everybody work with trauma. So you need
Okay.
to know what they're working with before you get engaged.
Okay. So, and my last question, I think, is that how, if somebody wants to reach you, how can they do that?
Yes. So my website is www.mentalhealthtalk.live, live, mentalhealthtalk.live, live. Dr. Leslie Rogers. I'm all over social media, LinkedIn, Facebook, um, and other platforms. But you can go to the contact us form on www.mentalhealthtalk.live, live.
Okay. And Dr. Rogers is also a member of the Rotary Club of World Disability Advocacy. Another way you can reach her is to write to us at rotarywda@gmail.com. And also, if you want to be a part of a world organization working to advocate for the human rights of people with disabilities, write to us also, and we'll talk about it. Okay, thank you very much, Dr. Rogers. It's been an interesting time with you, and I know we're going to do more. We're going to do more
I know the
because
time just goes by so fast. We can just go on and on.
but there's many, many more the subjects that you are versatile in. So we will certainly have you back at some point, and, and we'll do
Thank
other
you.
things with you too. So, okay,
Hmm.
very good. Thank you. Let me say
Thank you.
goodbye to everybody, and we'll see you next time.
Thank you, everyone.